Hello everyone, welcome to the Wolfson Centre Clinical Seminar Series. This series runs twice a year and it's aimed at practitioners working in the field of young people's mental health. My name's Olga Eyre and I'm a Clinical Research Fellow at the Wolfson Centre, and I'll be introducing our speaker today. But before I do, I just want to let you know that the seminar will last 1 hour today. The talk will last about 30 minutes and that'll leave up to 30 minutes for sort of questions and discussion. If you can post your questions via the Q&A box during or after the talk, and you should be able to see that at the bottom of your screen, that would be great. So it's my pleasure to introduce our speaker today. So Professor Kapil Sayal is a Professor of Child and Adolescent Psychiatry at the University of Nottingham and Honorary Consultant Child and Adolescent Psychiatrist. He leads the Children and Young People Mental Health and Wellbeing Research Group at the Institute of Mental Health in the University of Nottingham, and he's been appointed as an NIHR Senior Investigator in recognition of his outstanding leadership within the research community. So we're very, very happy to have him, and today he's going to talk to us about the standardised diagnostic assessments randomised controlled trial in child and adolescent mental health services. So over to you now, Professor Sayal.
Thank you so much, Olga, for your very kind introduction and invitation from yourself and the Wolfson Centre to speak with you today. Just bear with me while I just reshare my slides and just make sure they'll come up okay. Resume slideshow, just bear with me. Can I just check that you can see that? See that okay? If somebody could just shout out.
Yeah, I can see that.
Ah, perfect. Thank you so much. So it's a real pleasure to be able to speak with you today about the next half an hour or so about Stadia. So Stadia stands for Standardized Diagnostic Assessment for Children and Adolescents with emotional difficulties, and it's a large multi-center RCT that we've very recently completed, so relatively hot off the press, and I'm very delighted to have the opportunity to share the findings and our learning so far with you, but really interested to get your thoughts and feedback about this in terms of the implications for your services, your practice, and more broadly actually in terms of what it's telling us in terms of a thermometer about CAMS currently. So as many of you who will have worked will be familiar with randomized controlled trials, I'm presenting and leading this on behalf of a team of hundreds, and these are just some of my colleagues who've made this trial possible. And at the end, I'll give them another shout out and with the list of their photos. So at this stage, I would request, if it's okay, that as you are a pre-registered audience, this is very much an early view in terms of these findings. The main trial results haven't yet been published and not in the public domain. They have been accepted for publication and will be due out very early in the new year. So the main trial publication will appear in the Journal of Child Psychology and Psychiatry, the JCPP, and that's scheduled to come out in the first couple of weeks of January. But for now, I'd be very grateful that you don't take any screenshots or share further outside this meeting. So in terms of the outline of my presentation, what I'll do is I'll run through the background of Stadia, how it came about and what we did, then go on to the PICO, the trial PICO. That stands for participants who took part, the intervention, the comparator, and the outcomes that we assessed. Share with you some of the main findings from the trial, but then I'd particularly like to focus with you on the important implications for CAMS, both in terms of our current service models, service delivery models in CAMS, but also very importantly, the CAMS workforce, in terms of thinking about who, from the workforce point of view, who comes into CAMS, the professional training and background, and ongoing continual professional development and training that colleagues in CAMS continue to receive and undertake. So just a little bit firstly about the background and how this trial came about. So it's set in England, but our belief is that the methodology and the findings are very readily generalizable, not just to England, but also Wales and the rest of the UK, but even more broadly internationally, but particularly Europe, and other countries where healthcare provision delivery is state funded. The trial was led by ourselves in Nottinghamshire Healthcare, but very much in partnership with 8 large NHS trusts who provide CAMS across England, with a really good geographical spread, right from Manchester through to Gloucestershire in the west, and down to Surrey in the south of England. And it came about from the NIHR, the National Institute for Health and Care Research. The NIHR is basically it's the research arm of the NHS, and they commission and fund studies, they research, which has implications for NHS service delivery and service provision. And from time to time, they put out research calls on particular topics. This is across all of healthcare, including mental health and CAMS. And a few years ago, one of the topics that they put out inviting teams to bid for was around the use of standardized diagnostic assessment tools. I'll go on to call that SDA tools because it's a bit of a mouthful, within CAMS. And this came about following very wide stakeholder consultation. So in advance of putting the call out, they consulted broadly with parents, young people, a range of different clinicians across mental health, pediatrics and primary care, and also service commissioners. Because of the genuine uncertainty, genuine, in some ways, sort of controversy as well, I guess, around the role and the place of diagnosis within CAMS. So where there is genuine uncertainty in terms of whether a particular approach is better than current standard practice, in trials sometimes that's called clinical equipoise, meaning you're kind of equally balanced on each side, you really don't know which works. That could lend itself to a randomized controlled trial where there's a 50-50 chance of receiving either of those interventions. And the call came out with the research question of whether an SDA tool improves the detection and improves the treatment outcomes of emotional disorders in children and young people who've been referred into CAMS. And we got the go-ahead to lead this trial. And some of the kind of key background issues contextually, both in terms of CAMS and commissioning, are that, as many of you who work in clinical practice or researchers will know, there are very good evidence-based interventions available for a range of emotional disorders. And actually, if you go and check out various NICE guidelines, you'll notice that the names of the NICE guidelines, the names of those guidelines are based on the disorder, the diagnosis. So there are NICE guidelines for depression, that they're not called NICE guidelines for low mood. They're NICE guidelines for anxiety depression, not worries or just anxiety, and so on. But we also know from both clinical practice and research that very commonly in children and young people who are seen in CAMS, anxiety disorders and depression are often missed, and often difficulties are attributed or only attributed to specific other things, sometimes just risk factors. Going on then to thinking about CAMS assessments, they vary hugely. So firstly, if a child or young person who's been referred into CAMS is fortunate enough for that referral to have been accepted, who they get to see within the CAMS team, it can be a lottery. It can be very variable. Often it may depend on who's got capacity, who's got availability to see them. And CAMS is very broad, very multidisciplinary, with professionals from a range of different backgrounds, clinicians and practitioners. And so the actual assessment can vary according to who you see, certainly vary across different services. As I mentioned, there's uncertainty, there's equipoise about whether diagnostic assessment tools have any clinical value or make a difference. And as I've already alluded to, this of course all depends on getting as far as receiving an assessment. Many of you will know that a very significant proportion of referrals to CAMS get rejected, that they get turned away. Often that's termed or described as signposting, but very much feels like a rejection for the young people and the families involved, and of course the professionals who've been referring into the CAMS. So broadly, there's quite a lot of concern about access to receiving help in the first instance. So in terms of the Stadia research question, what we aim to answer is what is the clinical effectiveness and what is the cost effectiveness of an SDA tool, in addition to usual care, so as an extra, in diagnosing emotional disorders amongst children and young people with emotional difficulties who've been referred into CAMS. From a randomized control trial point of view, it's actually a very simple design. 50-50 chance of being allocated to receiving the SDA tool. We use something called the Dorber, and I'll come on to describing that and sharing that with you in a few slides' time. Adding the Dorber to usual assessment, so that's usual care, and comparing that with usual care. And alongside this, we also took the opportunity to run a nested qualitative and implementation study to get a better idea about attitudes of various stakeholders. So just a little bit about our logic model sort of underpinning the study and trial. And the way we were thinking about it, that in terms of the CAMS assessment, if it's possible to gather some important and relevant information before the assessment takes place, so gather information in advance, that hopefully means that the assessment process has a more timely and speedy conclusion. Ideally, that then leads to a diagnostic decision, whether that's around confirming a particular emotional disorder diagnosis or ruling things out and saying actually no diagnosis or disorder applies. That then helps to inform the most appropriate evidence-based intervention to be offered. And hopefully that means better clinical outcomes for the child or young person. And this hopefully is also a more cost-effective approach of doing things. If you're interested in a greater level of the methodology, then I'm able to share with you today the main trial protocol with information about all the measures and assessment tools that we use is available in the protocol paper, which is published in BMJ Open. It's an open access, freely available paper, and that came out a couple of years ago. So I'll go on now to the trial PICO. So firstly, again, starting with the P, the participants. This was a really large trial. Over 1,200 children and young people, aged 5 to 17 years, with emotional difficulties who'd been referred into outpatient multidisciplinary specialist CAMS. For those of you in England and other parts of the UK may have used similar terminology, this is what used to be known as Tier 3 CAMS. So that's a multidisciplinary service. But of course, some services have a more combined Tier 2 and Tier 3 model where you might see just a single professional from a particular discipline or have a more multidisciplinary input. As I mentioned, this is a really large trial, and we did check into this, and we're pretty sure that this is the largest RCT in the UK involving clinically referred children and young people to CAMS, and we think one of the largest internationally. The focus here was on routine referrals. So by that, I mean the referrals that might come in from a range of referrers in the community. Some services did take and accept self-referrals, but they come in and then they're looked at by a triage team. They can be called slightly different things, different places. A lot of places in England certainly call them the single point of access, the SPA team, but there are variations around that. But the focus was on routine referrals. So we're not talking here about the urgent or emergency referrals coming into CAMS. And then in terms of who took part and provided data, that varied according to the age of the child. So for 5 to 10-year-olds, it was the parents and carer who completed questionnaires and provided the data. For 11 to 15-year-olds, the parent and carer was the primary participant providing consent. And then with their permission, we were also able to approach the child who could also complete questionnaires and provide data on their own behalf. And then for 16 and 17-year-olds, we flip that over. So our first point of contact was with the young person, and then with their permission, their parent or carer would also take part in the trial. Going on now to the I of the PICO, the intervention. So as I mentioned, we use the DORBA. The DORBA stands for Development and Wellbeing Assessment, and some of you, particularly those working in research, will be very familiar with it. Those working clinically, perhaps a bit less so. So the DORBA has actually been around a really long time. It's been around over 25 years. And it was initially developed by the same developers of the SDQ, the Strengths and Difficulties Questionnaire, for our first really big national prevalence study of child mental health disorders. That was done in the late 1990s. That was Great Britain wide, so that included Scotland, Wales, and England. And it was the DORBA that gave us those early figures that around 1 in 10 children, young people meet criteria for mental health disorder. Since then, there have been 2 further very large-scale British mental health surveys, also using the DORBA. And since the pandemic, an abbreviated version of that. And gradually over time, and particularly over the last 3 or 4 years, that 1 in 10 figure has been gradually creeping up to now suggesting something more like 1 in 6 children, young people, so around 16% meeting criteria for mental health disorder. For the purpose from a clinical point of view, the DORBA is used a little bit in some clinical settings in the UK, but is used more widely in Northern Europe and Scandinavia. So it is a tool that is used clinically. For the purpose of the STADIA trial, as mentioned, it was offered and completed by the primary and secondary participants. And for the trial, we offered the options to our participants for this to either be completed online by emailing them a link to do this, or if they prefer to complete it with a researcher over the phone. And before we started the trial, we expected that about 2/3 would want to do it online and about 1/3 would take up the telephone option. We were really surprised, actually. What we found as the trial progressed and completed, that 99% of those that completed the DORBA opted to do it online and completed it online. So again, this I think is a really important take-home message in terms of routine CAMS, that our children, young people and families are very happy to provide us with information and complete information online, whereas currently a lot of CAMs still rely on postal or paper and pencil completed questionnaires, which are then entered manually by clinicians or admin staff. That ideally there should be a workaround because families are very happy to do this. In terms of using the DORBA, because this is a pragmatic trial in the sense that if we were to find it to be effective, find it to be cost effective, we want something that could be implemented relatively readily and cheaply within the NHS. So we use the version of the DORBA that relies on a computerized diagnostic algorithm. This is a very well validated algorithm. It's based on data from about 20,000 plus children, young people who took part in those national studies. And what it does, it indicates the likelihood of meeting a criteria for particular disorders being assessed. So in a way, it's a bit like the SDQ, where you have the different levels going from being in the average range, slightly elevated or high, did something very similar with the DORBA. But that also means, and it's really important to remember, the computer isn't making a diagnosis. What the DORBA is doing is highlighting the likelihood of meeting criteria for particular disorders, but ultimately it's about clinician judgment and clinicians incorporating and using this information alongside any other information that they're gathering as part of the assessment. Also, what was relatively unique about STADIA is that we wanted to share the DORBA findings with our participants. So with our patient public involvement, we created a very visual infographic of the DORBA report for that particular young person and sent a copy of that to the family. But also the DORBA report was shared with CAMS clinicians, initially with the CAMS triage or single point of access team, but also became part of the running electronic patient record. So it was there and it was available for further downstream clinicians who might be carrying out the actual assessment. And as I mentioned, this is in addition to, sort of alongside usual clinical practice. So just a little bit about the DORBA. What's really nice about it is that it is modular. So although it covers pretty much all of child mental health disorders, both for research and clinical use, you can pick and choose which modules you want to use. Now, this trial was commissioned around emotional disorders, so we therefore picked the range of anxiety disorders, depression, OCD, and PTSD. And in terms of the most common coexisting comorbid disorder, we also included the modules related to disruptive behavior disorders. This shows you just visually what the Dorber report looked like. So page 1 is really just highlighting how to interpret the infographic, and I will talk you through that in a bit more detail in the next slide. But essentially, it highlights that this report is really only a rough guide, only meant to be considered as a rough guide. So please use your judgment, because it's not the same as having a clinical assessment with a specialist based in CAMHS. And then going on to what it looks like on the second page. So on the left-hand side, for example, if you just focus on the first bullet point there, this is in relation to difficulties around worrying about a lot of different things, general fears and worries. So firstly, you'll notice there is the choice of language. And as I mentioned, the development of the Dorber report was done and refined through our patient and public involvement and partnership. I'll come on to a bit more detail about who were part of those groups. But stressing that it's not the computer making a diagnosis. So we're not saying that you're very high for generalized anxiety disorder, but that these difficulties are in relation to worrying about a lot of different things, general fears and worries. And then secondly, depending on the responses from the parent and the young person, the Dorber algorithm, what it does, it combines information from both informants in terms of their endorsements or not of symptoms and impairment, and based on that relates it to the algorithm and the population normative sample. And the particular group, you'll see in the infographic, it goes from green to red. And the particular group that we are most interested in and the most clinically significant ones are the ones that fall into the red, the very high category. So what that means is that's the worst 5% in the population. The other colours going from green through to amber are those where those difficulties are at a much less severe level, but they're very high, the most extreme 5% in relation to those difficulties. And here I share with you a real Dorber report from the trial. So this participant, where both the parent and young person took part, is a teenager. And for them, it highlighted that they were very high, i.e. they're in the worst 5% for general fears and worries. Also at the bottom reflects that they're also high or very high in relation to disruptive behavioral difficulties. But pretty much everything else is in the close to average range. And so this is also very reassuring. And many of the other Dorbers were like this. The Dorber is discriminating. If there were worries at the beginning that people might tick everything as being very high, perhaps in order to get a service, to get the referral accepted, that wasn't happening in practice. It was specific in relation to the actual difficulties that were being endorsed. So just a little bit about the process, how the intervention worked in practice within these are everyday real-world CAMHS. As I mentioned, once the Dorber report was generated, a copy was sent out to the family and the young person. It was uploaded to the CAMHS electronic patient records. As soon as that happened, the SPA team were told that the Dorber report was ready and available for their review, because up till now, the referral had been kept on hold. Now, I mentioned at the beginning, our focus in Stadia is on routine referrals. This was deliberate. This was because we needed to give enough time both for the research process to take place, i.e. getting in touch with the families and young people to let them know about the study, provide them information, give them time to think about it in terms of whether they wanted to take part, to be able to provide genuine informed consent. And then, of course, half got randomized to completing the Dorber. But we also unduly didn't want to hold up their referrals for too long. So our compromise position was 10 working days, which actually often meant there was only about 5 working days a week calendar time for young people and parents to complete the Dorba. But as soon as it was done and ready, the SPA team were told that they could then proceed with their decision making. And throughout the process, while the trial was running at our various 8 sites, the site principal investigators, like myself, regularly met with CAMS teams, doing presentations about the trial, showing what a Dorba report looked like, how to interpret it. So very similar to the presentation I'm giving now. And also our researchers added periodic regular reminders to the running records within CAMS and with links so that clinicians could see that there is a Dorba. There's participants taking part in Stadia. If you click this link, that will take you to their Dorba report. So that was the intervention. And as mentioned, that was all done in addition to assessment as usual. And we compared this with usual care. So assessments as usual, but not involving the Dorba. And then going on to the O of the PICO, the outcomes. So all trials have to have a primary outcome, and sample size is based on that primary outcome. And as I mentioned right at the beginning, this came about as a diagnosis trial. So our primary outcome was diagnosis based. And this was a clinician made and recorded diagnosis about the presence of emotional disorder. And this was the time period for this was 12 months, because we felt that was a reasonable amount of time between a referral coming into CAMS and a decision being made about a diagnosis. 12 months should be long enough. And what we were interested in was a recorded diagnosis of emotional disorder, like any anxiety disorder, depression, OCD, or PTSD. Of course, diagnosis isn't the be-all or end-all, so we looked at a range of other important outcomes, and service-related ones included whether the Dorba influenced the acceptance of the referral by the CAMS teams, whether treatments and interventions were offered and started, and if these things were applicable, how long it took to get to these points. And then also directly from our study participants. So young people and parents completed questionnaires in relation to depression and anxiety, as well as providing information around day-to-day functioning and quality of life. I've mentioned a few times patient and public involvement, and they were very much at the heart of Stadia and very much at the heart and right in the center of my presentation today. So in terms of hands-on and very direct involvement, right from the outset, right from when we were preparing our funding bid, a parent with lived experience of seeking help from CAMS for their child was a member of the study team and continued as a key co-investigator of the team. And through them, we also arranged another member of our study team to provide ongoing regular support and mentoring. And both this was Colleen and Alex, members of our investigator team, and they set up 2 advisory panels to inform and advise how we ran the trial right from the beginning. So we had an advisory panel that was for parents and carers, and also one for young people, which they called the Studio Youth Lab Workshop. And huge credit to them and to Colleen and Alex, because over the 6 years that Stadia has been running from start to almost end, we have retained all the original members of our PPI panels. And of course, that time period spanned a pandemic and several lockdowns during that time. So as mentioned, we got started and were up and running sort of really nicely in terms of recruitment through to early 2020. Then hit a halt because of the COVID-19 pandemic. It was very difficult of course for lots of reasons in those initial months. But as many of you will remember, by late summer of 2020, referrals increased hugely into CAMS at that point. So we're able to continue recruiting to Stadia right throughout that time period. And ultimately, we're only 4 months late in terms of reaching our target. And now in 2024, in a position to tell you what we found. And I'll be coming on to that over the next few slides. So just briefly going to summarize the PICO before I share the results with you. So it involved 1,225 children and young people who'd been referred to CAMS, young people with emotional difficulties who are routine referrals. We looked at the added value, the impact of adding the Dorber as an SDA tool in addition to usual care, compared with usual care, and then looked at a range of service-related and participant-reported outcomes. So going on now to the numbers, this you'll see in any trial report. This is called a consult flow diagram, which just shows you the participant flow right from getting in touch with them at the beginning right through to our primary follow-up. And the main thing really to highlight to yourselves is just what an excellent rate of follow-up there was, that we had very few withdrawals, which meant that at 12-month follow-up, we had data on over 99% of our initial sample. And then just a little bit about who took part. So firstly, just to reassure you, when you compare the intervention and control groups, they were very similar, very well balanced across the two arms. And then in terms of our participants, we had a good spread across the age range and broadly otherwise very much representative of who's referred to CAMS. So in terms of sex, just under 60% were female. In terms of ethnicity, about 86% white ethnicity, which is very much in keeping with national population figures for that age group in England. In terms of deprivation, a good spread, an even spread across the various deprivation quintiles. About a third had been referred previously to CAMS, and around 6% there was clear evidence of a previous emotional disorder diagnosis in the CAMS records. Just a little bit about what the Dorber found. Now, remember, the Dorber was offered to half the sample. So in terms of completion, and again, bear in mind that they only had between about 5 to 7 days to complete the Dorber. There were really good rates of completion. 80% of those offered the Dorber completed this, which meant that for them, we could generate the Dorber report and share that with participants and CAMS clinicians. And what did the Dorber show? So I just want to draw your attention to the three figures that have been highlighted here in yellow. So the first one here, from the second to bottom row, is scoring very high. And remember, very high is being in the worst 5% in terms of the community. In this routine referred sample to CAMS, 67%, that's 2/3, was scoring very high for at least one emotional disorder. And most commonly, that was depression or generalized anxiety disorder. Now, these figures relate to the whole sample, 5 to 17-year-olds. If we were just thinking about the older age group, the 11 to 17-year-olds, in fact, it was more like 3/4 scored very high for at least one emotional disorder, and 50% scoring very high for depression. So we are talking here about a clinically significant sample with significant levels of difficulties. This isn't just those with minor problems or the worried well, people that have clear high levels of need and in need of help, things that CAMS can support with. So now coming on to what we actually found in terms of the trial outcomes. So just for a second, I'd really be grateful to gather your thoughts. Perhaps if you wouldn't mind just using the chat function just for a couple of minutes. So remember, we assessed a range of different outcomes, starting with very proximal ones, whether influence referral acceptance within a couple of weeks, within a few days, a couple of weeks of the referral coming in, right through to diagnosis, through to mental health and day-to-day functioning. Just in the chat function, just for the next minute or so, I'd be really grateful if you could just put in either a yes or no. If a yes, if you think that the Dorber impacted even just one of these various outcomes, or a no if you think it had no impact on any. I'll just pause while you do that. Olga, I'm not sure if I can't see anything coming in my end, but maybe.
So it looks like the chat function isn't working. People are putting it in the Q&A. So people
Apologies.
are putting it in the Q&A.
Yeah, sorry. Please use the Q&A instead.
So I can see there's, I think, yeah, a few people have put some things in now, mostly all yes, actually.
All yes, okay. Just give people a few more seconds. I'm mindful of time, so we have plenty of time for our own Q&A as well. It's a great range of responses. Thank you so much. So absolutely, the majority thinking and expecting, so hypothesizing that there would be an impact at least on something, and very much that was our expectation and hypothesis. So I'll put you out of your misery and go on to what we did find. And I knew this would happen. By screen has just frozen for a second. So adding to the suspense, I'm afraid. Bear with me. Might just have to stop sharing just for a second. Sorry about this. Sorry, I do apologise. I normally don't leave people in so much suspense, but I will just stop sharing. And every time when I try and do something, here we are. Are we back on?
Yeah, looks good.
I hope so. Okay. Ah, good. Okay. So what did we find? So primary outcome was around diagnosis, and in fact, the Dorber made absolutely no difference whatsoever. So in going forward in the next few slides, I'd like you to think about these results in terms of two stories, two overlapping stories. One is the trial story. So what I will be sharing with you is the two arms, the those that received the Dorber and those that didn't, and comparing them. But also think of this as a cohort. So this is a representative sample of children, young people with emotional difficulties referred to CAMS, probably one of the largest of its kind, and very similar to those of you clinicians whom you might see in CAMS. What happens to them over the 12 to 18 months period following that referral? So they're two sort of parallel overlapping stories to think about. So here, what really stands out is firstly that there was no difference. The Dorber made very little difference. But I think even more strikingly was how uncommon, how rare it is for diagnoses to be made in CAMS. So overall, only between 11 to 12% of the sample, remember 67% was scoring very high for at least one emotional disorder as suggested by the Dorber, but only 11 to 12% received a clinical diagnosis of an emotional disorder. And I will put you out of your misery in terms of the rest of the slides as well. This pattern of no difference between the two arms was replicated across all of our outcomes. So one of the main trial take-homes in terms of the results is that the Dorber made absolutely no difference in comparison to usual care. And again, in our Q&A, we can, in discussion, we can have a think about why, possible reasons why that might have been the case. Breaking that down a little bit more in terms of our primary outcome. So at the bottom in blue are the 11 and 12%. But if I could just draw your attention to the box with the grey. So on the intervention group, that says 28%, in the control groups, 22%. So the grey here is where there is unclear, uncertain information about diagnoses. So if we take the example of OCD, if it's clearly documented OCD, that would be a diagnosis. But this would reflect in clinical records where clinicians instead record or note OCD-type problems, OCD-type difficulties or symptoms, obsessions or compulsions. So it's not quite a diagnosis. They're uncertain, or there's using softer terms, or there's diagnostic hedging. And perhaps there is a suggestion that those in the Dorber arm, at least there was a bit more of an attempt to record something along diagnostic lines, although it wasn't a clear-cut diagnosis. Now, this was a 12-month follow-up, and as I was mentioning earlier, of course, the trial ran during the time of the pandemic. That had a huge impact on waiting list and waiting times. So in some places, the first assessment didn't even take place until after 12 months after the referral had come in. So we did a slightly longer term follow-up, looking at 18 months to see whether that made a difference. But again, no difference between arms, and even by 18 months, only 14%, 14 to 15% had received a clear emotional disorder diagnosis. Similar story if one looks at the greys here. So the uncertainty again slightly more in the Dorber group. So perhaps the Dorber led to some attempt to write something down, record something, but again not a clear-cut diagnosis that could be adjudicated as being definitive. Our most proximal outcome, time-wise, was referral acceptance. And here there was a hint. If you look at the blue bars compared to the red, the blues are slightly higher, but the Dorber did have a very small impact on increased likelihood of referral acceptance, although it wasn't statistically significant. So those risk ratio numbers that you see in the middle that go from 1.03 to 1.06, what that means is there was somewhere between a 3% chance and a 6% increased chance that your referral was accepted if the Dorber was completed. And that was on the left-hand side. That was the index referral, the referral that brought you into the study and into CAMS. And then on the right, that, of course, because so many referrals were turned away, they were often re-referrals. So the right shows you whether any referral by 18 months was accepted. So possibly a slight increase. But again, the second story here is how many referrals were turned away, were rejected. High need sample, 2/3 scoring very high for emotional disorders on the Dorber. Despite this, only 44% had their index referral accepted. Around a third were then re-referred, but even by 18 months, less than 60% had had a referral acceptance to CAMS. So a significant proportion don't receive any CAMS input at all. In terms of getting help, again, if you just look at the final column that we have, by 18 months following the referral coming in, less than half had had an intervention offered through CAMS, and only in about a third had that intervention commenced. Most usually for those figures that was a psychological based intervention. And then in terms of our participant outcomes, again, we had really good rates of follow-up questionnaire completion by young people and parents and carers, both at 6 months and 12 months. Again, this really highlights that those of you that collect PROMs, patient-reported outcome measures, routinely in CAMS, our families are very happy to provide this information online. It's something we need to tackle from NHS systems in terms of our actual systems and our firewalls to be able to accommodate that. But in terms of what participants told us, I'm afraid it's very much a continuation of that bad news story. I'll just give you a few selected highlights in terms of some of the self-reported findings. So firstly, starting with depression, the mood and feelings questionnaire. This is a nice guidelines recommended questionnaire for depression. Those of you familiar with it will note that a cutoff of 27 or more signifies severe depression. Even 12 months down the line, the average score was 34, so well above depression, well above cutoff for depression. That's self-report. It's lower for parent reports, but of course that parent report figures reflects the whole 5 to 17-year-old age group, and of course depression scores generally are much lower amongst the 5 to 10-year-olds. So this really highlights that in terms of depression, these children, on average, these children and young people were not getting better. But not only that, around a quarter were deteriorating. 12 months after being referred into CAMS, around a quarter were doing worse in terms of that depression. So this figure highlights those that at 12 months, they're scoring 27 or above, but also their score on the MFQ has deteriorated by at least 5 points. Similarly sobering story in terms of day-to-day functioning. Those of you familiar with the strength and difficulties questionnaire will know it's got a very nice set of questions around functional impact. The cutoff for significant impact is a score of 2. 12 months after coming into CAMS, on average, the scores, both based on self-report and parent report, were around double that. So these children, young people are really struggling in terms of the impact on their day-to-day lives. Similar for self-harm, this is self-harm 3 or more times in the past 6 months. Around a quarter of young people reported that, and of course those figures are much higher in relation to 1 or 2 episodes of self-harm over that time period. So this is where we are at so far in terms of the main trial findings. I'll just wrap up very quickly in terms of what our next steps are and a summary, and then hopefully we have 15 minutes or so for questions and discussion. So we're currently unpicking the data that we have a bit more, got really rich data set, large sample followed up over 12 to 18 month periods to look at which factors predict and who gets seen, whose referrals accepted, who gets help in terms of receiving intervention, and importantly, of course, who gets better in terms of what are the predictors of outcome. We're also currently doing a 3-year follow-up in relation to our sample, linking our Stadia data with routinely collected NHS data that exists through NHS England. And for our discussion, I'd like you to consider and please to ask questions around these 2 stories. So as I mentioned, this is although routine referrals, we're not even talking here about urgent or emergency referrals. Routine referrals, very high levels of mental health needs. In terms of the actual trial, the standardized diagnostic assessment tool didn't have an impact on any of the outcomes, other than perhaps contributing to a small likelihood in referrals being accepted. Of course, that referral acceptance things could work either way. A low DORBA might justifiably mean actually that CAMS input isn't warranted or relevant at this time. And overall, only 11% receiving an emotional disorder diagnosis. And I think that this also raises questions and issues in terms of CAMS. So firstly, is our service model, which in many places, community CAMS, the model is still based on a setup that was put into place in the 1990s. Is it still fit for purpose based on current levels of need, prevalence, and types of difficulties presenting? Also, I think a bit about who's working in CAMS and the level of background, training and knowledge around mental health disorders. I mentioned our qualitative work. What it really very strongly identified from clinicians was a very strong reluctance to diagnose. Everything was about formulation. The question is, can't we be doing both, formulation diagnosis? Interviews with young people and parents were very telling. They were keen to be offered the option, the choice to be able to think about diagnosis, that it was offered for them, but were very nuanced about it, that wasn't seen as being the be-all or end-all. It was very much a starting step. And certainly commissioners were keen and interested that they could receive diagnosis information. And then just finally, just a set of thank yous, of course, to our young people and parents taking part, a huge number of researchers and our oversight teams that made the trial possible, and of course our funders, the NIHR, and the trial sponsor. And then finally, just a very quick shout out to key members of our team, our various PIs and leads across our sites and our trials unit, our other trial unit, trial management team and health economics team, without whom this wouldn't be possible, and really crucially, amazing site researchers across all of our participating trusts. So I'll end there with some of the kind of key issues that this has raised for us, and we'll stop there. Olga, would you like me to stop sharing or leave this up?
It's up to you, really. I mean, you can leave it if it'll help people think about questions. Maybe there's one question so far, which is in the Q&A box. I don't know if you want me to read it out. It's quite long, but I will do so everyone can hear. So it's from Fran Rice saying, very impressive work. This seems a somewhat sad story. There's a huge discrepancy between the rate of diagnosis according to diagnostic interview and clinical assessment. Also, so few people receiving help. Does this imply that young people are underdiagnosed in CAMS? Cynically, this may be used as a method of managing the provision of care in a very overstretched system. Alternatively, it may be underdiagnosis for other reasons. Interesting that there were hints that the Dorber helped lose some uncertainty in Cam's diagnosis.
Thank you, Fran. Firstly, thank you for very kind feedback about the study. And no, absolutely, really good questions there. I think there's probably a number of different sort of stories and answers to this, and I'm also very mindful to put this into context, I guess, of the more kind of public health and population narrative currently around children and young people's mental health, where I think there's a lot of concern in the background around self-diagnosis, inappropriate self-diagnosis, and sort of self-labeling. And although to some extent that might be going on, I think it's a very nuanced picture that this isn't just about overdiagnosis versus underdiagnosis, more broadly, but both aspects are coexisting. So another way of thinking about this might be more in terms of kind of false positives and false negatives. But I think this really does raise very huge concerns amongst very, very high levels of need coming into CAMS, certainly need and demand exceeding currently available resources, and which I sort of flagged, is our current model the right one for the changing population need? Children and young people now may be different overall to those from 25 or 30 years ago when services were set up in this way. I certainly don't think it's necessarily kind of a cynical way of managing things, because it can also raise the question of, does diagnosis matter? If needs are properly identified and the right evidence-based interventions are offered, and okay, and if all we did was formulation, what that should still mean is that children and young people get better, that the outcomes are good. But unfortunately, that doesn't seem to be the case. So leaving aside even whether one should diagnose or not, what we're currently doing, and in the vast majority we're not diagnosing, these children and young people unfortunately aren't getting better. So I think this really does call for quite a radical rethink. And I'd be really interested in views of clinicians and those working in NHS Wales. We've certainly been having some really interesting conversations with equivalent colleagues in NHS England. That does this rich data set actually provide that opportunity for a rethink of our models?
Thank you. There's a couple more questions. First one says, do you have the sense that clinicians' reluctance to diagnose is associated with their attitudes and adherence towards NICE guidelines or evidence-based treatments?
Thank you. That's a really good question, actually, and I don't think we'd actually thought of that specifically, drilled it down to that level, around NICE guidelines, specifically. Certainly, what came out very, very strongly amongst the interviews, and we carried out over about 100 interviews across a range of stakeholders, young people, parents and carers, clinicians, service team leads, and managers and commissioners. But certainly, from the clinicians' perspective, I think it was a combination of things. I think partly it was about discomfort, relating to own professional background and training. Certainly a very strong wish and need that formulation is the only thing and the most important thing. I think sometimes concerns about perhaps where it was perceived that certain young people, certain families were specifically diagnosis seeking, and I think that sometimes may have set that such big mismatch in expectations across both parties, that were there. But as I mentioned, our young people and families were really much more balanced and nuanced about it. I think they wanted to know, but they wanted to know so that it allowed them to access the most appropriate help. And sometimes, of course, we know it's not necessarily the families or even the CAMS clinicians that are that have the diagnosis question foremost in the mind. Sometimes it's more for external agencies, such as schools, so that different or additional resources can be put into place. But really good question, and we'll go back and recheck our data around specific mentions around NICE guidelines.
The next question you might have sort of already touched on, really. It says, excellent work. I'm wondering what the parental or young person perspective is on diagnoses. So sounds like you've sort of covered some of that. Yeah. So
Yeah.
then I think the next one is repeated from above. So there's another one. Were you able to explore whether the assessment affected treatment decisions, i.e., whether evidence-based treatments were selected more often when an assessment took place?
So obviously at the first level, many of these children, young people weren't able to access help at all. So even by 18 months, less than 60% were even seen. So if they did access anything, it would have been outside of CAMS, sometimes through third sector organizations. Anecdotally, sometimes we're also hearing, sadly, that some young people and families were having to go privately, but we don't know what they actually were offered and received. Um, I think again, it's really hard to say from the data. We specifically we had to be very measured and very specific in terms of the data we collected. And those of you working CAMS will know, particularly if you use electronic records, just how many different tabs there are, how difficult it is to even if you're looking for something in CAMS that you need, sometimes you're having to click in about 5 or 6 places to get that. So it could often be difficult to say whether the assessment that the intervention that was offered was necessarily evidence-based in relation to those particular difficulties, because there was a gap in the clinical records. Often we know diagnosis was hardly ever recorded, but often even the formulations weren't necessarily as clear cut to say the match was right. And anecdotally, sometimes it may have been more around therapist or therapy availability in terms of what could be offered first.
Great, thank you. That's all the questions on there. I mean, I had one question, if that's okay, and that
Of
is,
course.
to what extent do you think that the clinicians used the doorbell to make their decisions? Like, did they understand it? Did they spend time looking at it? You know, that sort of thing.
It's a really important question, and it's not one that I can give you a definitive answer in terms of us knowing in what percentage the doorbells were accessed and looked at. In an ideal world, we would have been able to do that. The challenge here is because everything was happening through the electronic patient records. There is no way for us to know as a research team, and I don't think even necessarily NHS trusts will know unless they've got a Big Brother model working, in terms of knowing exactly what a clinician is clicking in terms of the records, in terms of various reports or various tabs or various uploads. So it is an unknown. What we do know is that certainly the proximal clinicians, so those clinicians based in the triage teams making a decision about the referral, because we work so very closely with them and informed them as soon as it was available to look at, we know that in the vast majority of cases they did look at the doorbell. Now, again, we don't know to what extent, in terms of how long they spent looking at it, whether it was a quick eyeball or whether they spent time looking at it. And the findings perhaps suggest that hint that it had possibly had a little bit of an impact there, but that, as I mentioned, that could have balanced out the other way as well. Because actually they're trying to decide with finite resources who should be seen and who should be signposted elsewhere. But then further, more downstream, we don't know. It is certainly a limitation of the trial and the trial design. Ironically, it might have been something easier to have known if we'd done this 15 years ago and we had paper and paper records. I remember those days where you could stick something with an elastic band on the front of the notes and a little checklist or checkbox asking clinicians to tick it if they'd seen it, and we would have known from that point of view. But with electronic records, that's much harder. But it may well be that many of the doorways weren't seen. And that's partly, I think, also a reflection I mentioned about we having to go back over and over, back to teams to tell them about the study and the reports. CAMS services, CAMS teams also have very high turnover of clinicians. And we certainly noticed that often when we were going back every few months, there were many new people starting in the team.
Thank you. No, it is 3 o'clock. There's one last sort of comment in the box, so I'll read that and then I think
Of course.
will be the end, but it's from Dave Williams. It would be useful to see whether the DORBA could improve the matching of evidence-based interventions to the diagnosed or diagnosis type issues group. As regards future models, we need to change, and diagnosis needs to be within the context of a formulation. Wales need an electronic record too, though.
No, that's a really, really good point. So perhaps if I pick up your latter point first there, I mean, absolutely, and I work clinically as well, and we see in our clinic young people referred with a question around diagnosis. I run an ADHD clinic, but we always aim to think and provide diagnosis and formulation, and very much see that as two sides of the same coin. You need both. They go hand in hand with each other, and it's really important that one part of that message isn't lost in the wash sort of going forward. And absolutely, we are now in the position that we can unpick our data a bit more and do some secondary analyses. So to potentially to be able to look at, well, what did the DORBA say? Did the DORBA itself make a difference then in terms of which diagnoses were offered and what interventions were given? Because I think potentially our qualitative work highlighted that young people and families really like doing this, and clinicians could very much see the value of it. Commissioners certainly could, because actually there wasn't a demand, a burden or a demand on clinicians in relation to this. The information was provided for them. It's then about thinking about how it could be best used. But of course, one of the main take-home messages at the moment is that based on this, there isn't the research evidence to say that this should be rolled out or implemented routinely. It certainly needs more careful thought in terms of how and where it's done.
Thank you very much. Okay, so I think that's the end there now. We'll leave it there. So just again, thanks very much for such an interesting talk and for joining us today.
It's a pleasure. Thank you so much for the invitation, and thank you so much for everyone in the audience. Apologies that we overran a little bit, but really appreciate your time and interest. And paper will be out very soon, so we'll make sure we share a link with the YouTube recording. Thank you.
Thank you. Bye now.
Cheers. Bye.